Hello everyone, this is Dr. Meenakshi Gupta from the Conceptual Pharmacology channel. Today I am going to take another topic of pharmacology, that is anticholinergic drug or parasympatholytic drug. So for this video you should be thorough about the general introduction of ANS and parasympathomimetic drug. So if you haven't read those topics, so before watching this video you should be thorough about those. So let's quickly revise. So this is the central nervous system, okay, for the brain and the spinal cord. And from the spinal cord, the cell body, neuron, it is arising and it will terminate here, and from here another neuron that will arise and it will terminate over here. So there are two neurons, one is a preganglionic and postganglionic. We have a preganglionic neuron and we have a postganglionic neuron, and this is a ganglion. And the neurotransmitter here, it is a acetylcholine, and this acetylcholine, it is going to cause the depolarization throughout this preganglionic neuron as well as the. So first preganglionic neuron will come here, again from here acetylcholine that is released, which is going to further cause the depolarization through the postganglionic neuron. Now this is going to make a connection with the effector organ or effector system. So effector system, it can be heart, it can be eye, or it can be any. Okay, so it is going to make a connection with the effector system. So on the effector system, different neurotransmitter, they are there. So could be here. So what are the receptor? They are there. If it is a parasympathomimetic, then it is a muscarinic and nicotinic. But you can see the another diagram. So if it is a parasympathomimetic, this one, this preganglionic neuron, this is a postganglionic neuron. If it is a parasympathomimetic, then what is the receptor? It can be either muscarinic or nicotinic. If it is a adrenergic or sympathomimetic, then it will be alpha and beta. So here, because I am going to discuss anticholinergic drugs, so I will be mainly focusing this cholinergic neuron. Now this cholinergic neuron, it is going to make a here connection with the effector system. It can be, I told you, heart, it can be blood vessel, it can be other viscera, it can be eye, it can be gland, any of this organ. So this figure I have taken it from the KD Tripathi. So now I am focusing this part, this receptor, where it is going to make a connection with the effector system in the next figure. So this is the end portion of ये वाला जो end portion है neuron का, this end portion, this. So this round thing is this end portion of this. ठीक है, ये जो round है, this is the end portion of the neuron, and this is the effector system where the effector organ can be any. It can be heart, it can be any viscera, it can be bronchus, it can be eye, it can be gland. So this acetylcholine, if it is a parasympathetic nervous system, they are going to act with the two type of receptor. One is muscarinic and another one is a nicotinic. So this acetylcholine, it is going to bind with the muscarinic receptor and the nicotinic receptor, and it is going to exert its action. Now what the anticholinergic drug they are going to do? If you are going to give the anticholinergic drug, they are going to come. Now anticholinergic drug, how they are going to act? So they are the competitive antagonist. See next figure. So anticholinergic drug, they are going to bind only with the muscarinic receptor. Okay, So there are two type of receptor. We have a muscarinic and we have a nicotinic receptor. So ideally the anticholinergic drug, they should bind with both type of receptor. They should oppose the action of acetylcholine. So they should oppose both muscarinic action as well as nicotinic action. But anticholinergic drug, they mainly block the muscarinic receptor, not nicotinic. इसको नहीं करते. They only block the muscarinic receptor. So they prevent only the muscarinic effect of the acetylcholine. No, that's a big no. No effect on the nicotinic receptor. This is very, very important. So anticholinergic drug, this is a misnomer. This is a misnomer. It should be anti-muscarinic drug. So topic का क्या नाम है? Anticholinergic drug, parasympathetic drug, but the appropriate terminology, it should be antimuscarinic drug. So if you want to block this action of nicotinic receptor, so nicotinic receptor, they act by two type of receptor, NM and NN. So anticholinergic drug, ideally they should block both muscarinic as well as nicotinic receptor, should have anti-muscarinic action or anti-nicotinic, but they mainly exert this action and this is not blocked by this. So to block this nicotinic action, we have a neuromuscular blocking agent. आपके पास ये है neuromuscular blocking agent and ganglionic blocking agent. So neuromuscular blocking agent, I have made a video. I will be giving a link in the description box. You can go and watch that video if you haven't seen that. Now mainly focusing on the anticholinergic drug or so-called antimuscarinic drug. Now how they are going to act if you are going to give. So what is the mechanism of action? Again focusing the same drug, same figure, sorry. So this I have taken from the KD3 party. So what the anticholinergic drug they are going to do? They are, number one, remember one thing, they are competitive antagonist. So they are basically antagonists. Now what are the antagonists? If you remember your general pharmacology, antagonists, they do not exert any action of its own. They are going to oppose the action of agonistic drug. So they have affinity. So their important characteristics क्या है? They have affinity but no intrinsic activity or efficacy. No intrinsic activity with this. So what is affinity? Affinity is, it is a tendency of the drug to bind with the receptor. So this anticholinergic drug, they are going to bind with the receptor. Suppose the prototype drug of anticholinergic, if it is an atropine, I have given the atropine to the patient, patient has taken, it will come and bind with the muscarinic receptor, but it does not have any intrinsic activity, so no action will be exerted. So atropine, it will come and bind here, it will sit on this receptor, it is going to occupy this seat. Now the acetylcholine, when this comes, it will not get this seat because muscarinic receptor, they are blocked. So acetylcholine, it will not be able to exert its action. So this is how the anticholinergic drug, they are going to act. So they are the competitive antagonist. They come and bind with the receptor, and by this what will happen? The agonist won't be able to exert its action. So this is about the mechanism of action of anticholinergic drug. Now coming to the pharmacological action, or what kind of pharmacological action this group of drug they are going to produce. So if you know how the parasympathomimetic drug, what are their pharmacological action, it will be easy to remember the pharmacological action of the anticholinergic drug. So remember one thing, the parasympathomimetic drug or a cholinergic drug, so how they act? They are going to inhibit the action. Their inhibitory effect is on the heart, and on rest of the system they exert the stimulatory effect. So I'll write here. So parasympathomimetic drug, parasympathomimetic sympathomimetic drug, what they do, their inhibitory effect on the heart, ठीक है, whereas stimulatory effect with a stimulatory effect at all other places. Okay? So now how this parasympathomimetic drug they exert their action? They exert their action by acting through three type of receptor. So muscarinic. So initially I told you M1, M2, muscarinic and nicotinic. But then I told anticholinergic drug, it is a misnomer. So it is going to exert only its action on the muscarinic receptor. It is going to antagonize the action of parasympathomimetic drug, which is only by the muscarinic receptor. So there are three type of muscarinic receptor. They are there mainly M1, M2 and M3. So M1 mainly it is in the stomach, this one in the heart, and this one M3 it is at many sites, at many places. You can say it is present in the smooth muscle. So smooth muscles may it can be bronchi, then it can be urinary bladder, it can be intestine, it can be ureter, it can be bile duct, it can be blood vessels. Okay? So this is a long list. And where else it is there? So this is a one smooth muscle. ये हो गया आपका. And then another site is the smooth muscle. Then number 2 is glands. And number 3 is eye. Okay? So what I have told, this parasympathomimetic, they have inhibitory effect here. यहाँ पे inhibitory effect है, whereas everywhere it is a stimulatory effect. So parasympatholytic drug, what they are going to do? There will be positive action here. At rest of the places, it is having the inhibitory action. So in the next now, I will be discussing the anticholinergic drug depend on the basis of its receptor. Like if I take up the M1 receptor, see M1 receptor that is present in the stomach. So stomach may have, so what is the action of this M1 receptor in the stomach? It is going to increase the HCl secretion. So number 1, M1 receptor, where it is present? It is present in the stomach. So in the stomach, this M1 receptor, they are going to cause the secretion of HCl. Now how basically this HCl? So remember, it is ultimately the parietal cell which is going to cause the increased secretion of HCl. That last step of HCl secretion, that is happens in the parietal cell. And on the surface of the parietal cell, it is M3 receptor which is present. Now where the M1 receptor they are present? It is present in the stomach. In the stomach, it is the enteric nervous system. So we will say in the stomach it is a M1 receptor. They are there. Now this M1 receptor, once it gets stimulated, what will happen? ACH will be released. Now this ACH, it is going to act on M3 receptor which is present on the parietal cell, and ultimately it is going to cause the increased secretion of HCl. Suppose if I block this receptor, if I give a drug which block this receptor, M1 receptor, there will be no release of ACH. It will not act on M3 and there will be no secretion of HCl. Now, why I have explained all that? Usually the student, they see this picture ki on the surface of the parietal cell or on the parietal cell, it is a M3 receptor. So, maybe this M1 receptor, they are going to decrease the HCl secretion. Maybe it is wrong. So, we need a M3 receptor antagonist. So, it is not M3 receptor antagonist. It is M1 receptor blocker. So, by blocking this, there will be no release of, I again repeat, by blocking M1 receptor, there is no release of acetylcholine, and this acetylcholine will not act on M3 receptor which is present on the surface of parietal cell. So, there will be no secretion of HCl. So, it is the M1 receptor which is present in the stomach. Now, what are the drugs here? We have a pyrazipine, and talenzapine. So, how they act? They act by blocking the M1 receptor. So, I told you all. So, their mechanism of action is they block the M1 receptor in the stomach. By blocking the M1 receptor, the acetylcholine, it is not released. So, it is not going to stimulate the M3 receptor which is present on the parietal cell. So, there is decreased secretion of HCl. So, this is its mechanism of action. Now, where we can use this one? This we can use in peptic ulcer patient. Okay. Now, what are the, in the next column which you are not able to see, it is a adverse effect and, you can see, so adverse effect and contraindication, that is in the next column. Okay. Adverse effect and a contraindication. So, what are the, because of that, what is the adverse effect and the contraindication? So, usually this pyrazipine and talenzapine, they are M1 receptor antagonists. They are the selective M1 receptor antagonists. So, we use selective M1 receptor antagonists. So, can we use the non-selective like atropine? Can we use the atropine? So, what you will be reading, see, M1 receptor antagonists, they are used for the peptic ulcer, whereas if you read the contraindication of the atropine is peptic ulcer. So, this sounds very strange. See, peptic ulcer, so contraindication of atropine, that is a peptic ulcer. Means what I want to say, we can give the selective M1 receptor antagonist like pyrazipine and talenzapine, okay, for the treatment of peptic ulcer, whereas atropine, that is contraindicated. Now, why it is so? Atropine, it is a non-selective muscarinic receptor antagonist like M1, M2, M3. It is going to block all three. Now, we are concerned about M3. So, by blocking this M3, it is going to decrease the peristaltic movement in the GIT. So, by that, it is going to decrease the even gastric motility. Now, if the gastric motility is decreased, then what happens? Suppose here the ulcer is there, peptic ulcer or duodenum, if there is an ulcer is there. So, what happened? Because of decreased motility, if we are going to give the atropine by action with the M1, it is going to decrease the acid production. But whatever acid is there, it will remain here because of the decreased gastric motility. Ab ye gastric motility nahi ho rahi, then what will happen? There is no further movement. So, if the ulcer is there, what will happen? That acid, it is going to cause the damage to that ulcer. So, atropine, it is contraindicated in peptic ulcer. So, we give the selective M1 receptor antagonist. So, this is about the M1 receptor. Now, coming to the M2. Now, M2, it is present in the heart. So, already I have told this is going to inhibit. So, parasympathomimetic drug, they inhibit the heart and stimulate rest of the organ. So, inhibitory action of parasympathomimetic drug, So all the negative inotropic, negative chronotropic, dromotropic, so it is going to decrease the heart rate, decrease the conduction. So if I am going to give the cholinergic drug, or sorry, anticholinergic drug or parasympatholytic drug, so what are their action? They are going to cause the increase heart rate and increase conduction. So that means where we can use, if this is its action, where we want to increase the heart rate in, so uses will be in a bradycardia, जहाँ पे bradycardia where heart rate it is decreased, so there we can give the anticholinergic drug. And where we want to increase the AV conduction, और जहाँ पे AV conduction की slowing है, if there is a AV conduction, if it is decreased, so these are the two conditions where we are going to use this anticholinergic drug. Now, which anticholinergic drug? It is used for the treatment of bradycardia and decreased AV conduction. जहाँ पे bradycardia होगा, we are going to give the anticholinergic drug. It is going to increase the heart rate, and where AV conduction, if it is there is a slowing of AV conduction, then also we are going to give anticholinergic drug. Now here the drug is atropine. It is a non-selective because this is the most potent which is going to block this M2 receptor. Now coming to the number 3, which is a number 3, it is a at many site. So I'll take the smooth muscle. So in the smooth muscle, the first is I'll take the bronchus. So parasympathomimetic drug, they cause the bronchoconstriction. Now this is going to cause what? Bronchodilation. It is going to cause a bronchodilation. Now where we can use this group of drug? One is bronchial asthma and another one is chronic obstructive pulmonary disease, that is chronic bronchitis and emphysema. Now which anticholinergic drug we are going to use for the treatment of bronchial asthma and COPD? Okay, mainly it is a COPD. This should be number 1 and this should be number 2. So we have a drug ipratropium, we have a tiotropium, and we have a oxytropium, and all these we give by inhalational route. So this is the therapeutic use of this. This causes the bronchodilation. Because of that, we use it for the COPD, chronic obstructive pulmonary disease, and we use it for the bronchial asthma. Now, what is the adverse effect of this group of drugs? So we give it by inhalational, usually by the nebulizer. So it causes the, though it causes the bronchodilation, but there is a initial bronchoconstriction. So इसने क्या करना? Bronchodilation, but it also causes the constriction. This is called paradoxical bronchoconstriction. So this is because of, if in the nebulizer, if you are using, there is impurities, they are there, like EDTA, then we have a benzalkonium, then if you are using the hypotonic saline, that can also cause. Then another important is because of its action on the presynaptic muscarinic receptor. We'll see presynaptic muscarinic receptor, whether it is going to cause the inhibition or it is going to cause the stimulation. So it is so that is very, very important. Just see, then I'll complete this one. Right? This is a neuron, presynaptic, and this is a postsynaptic, where we have a muscarinic receptor M3. So here what happens, the acetylcholine, it is released, it is going to act on here. Now I am giving the ipratropium. क्या मैंने दिया drug? I have given the ipratropium. Now this drug, it is going to block this receptor, but what happens here, there are the presynaptic receptor, they are also there. Now presynaptic receptor, how this receptor it is going to act. So this can be M2 or it can be M3. Okay, so autoreceptor, how they act normally, just like you have read in the hormones, the 3-tier system you read in a hormone. So once like I'll make here, you read hypothalamus, then pituitary, and then target organ. Okay, from here the releasing hormone, here the stimulatory hormone, and here what happens, the target. Suppose if it is a thyroid, we have a T3 and T4. Now what will happen, it is going to inhibit this, and then what will happen, the further release of this will not happen here. And same thing here also, once this acetylcholine it is released, now what happens, this acetylcholine it is going to act on here, okay, on the presynaptic receptor also. It is going to stimulate this also. The stimulation of this, it is going to inhibit the further release of acetylcholine. So what I am using, the stimulation of the presynaptic receptor, the stimulation of, this is very important concept, stimulation of the presynaptic receptor inhibit further release of ACH. And if we are going to block inhibition of presynaptic receptor, will cause what? There will be release of acid, just it will be opposite. So we are giving the ipratropium. If you are going to give the ipratropium, now what it will be doing, it is not only blocking this M3 receptor postsynaptically, it also block this presynaptic receptor. So by blocking the presynaptic receptor, what will happen? Initial there is increased release of this acetylcholine, which is going to bind postsynaptically and causes the bronchoconstriction. But later on what happens, even if it is going to block this also. So this paradoxical bronchoconstriction, it will be very transient. बहुत थोड़ी देर के लिए होता है. So this happens transiently, थोड़ी देर के लिए होता है because of this. So this is another reason of paradoxical bronchoconstriction. So this is a M3 receptor on the bronchus. Now where else M3 receptor they are there? So M3 receptor, and another important organ for the M3 receptor is urinary bladder, smooth muscle. So in the urinary bladder, the parasympathomimetic, just like a bronchus में क्या करती, bronchoconstriction, or when we give anticholinergic drug, it causes the bronchodilation. Here also the detrusor muscle, the parasympathomimetic drug, they cause the contraction of the detrusor muscle. Now parasympatholytic drug or atropine like drug, what they are going to cause? They are going to cause the relaxation. Okay, they are going to cause the relaxation of this detrusor muscle. So if it is going to cause the relaxation of the detrusor muscle, then what will be the adverse effect? Or sorry, where we can use it, where you want the relaxation of this detrusor muscle, where we want, it is in a urinary incontinence, या फिर जहाँ पे bladder irritability or detrusor instability, there we can use. Okay, so now what will be the adverse effect of this? It is going to cause the urinary retention. And contraindication इसकी क्या होगी? Contraindication will be if the person is having benign prostatic hypertrophy, then this drug should not be given. This anticholinergic drug, they are contraindicated if the person is having benign prostatic hypertrophy because of this adverse effect, urinary retention. So we are using it for the urinary incontinence, we are using it detrusor instability. Okay. Now what are the drugs which we can use for this? We have drugs solifenacin, oxybutynin, flavoxate, tolterodine, and derifenacin. So these are 5 drugs which we use for the urinary incontinence, and out of this solifenacin and derifenacin, they are vesicoselective. Okay? They are vesicoselective. Now another this one organ or another site where M3 receptor they are present, that is in the colon or intestine, then in the ureter, I am taking all the 3, then in the bile duct. Now what they are going to cause here? Here also they are going to cause the relaxation. Now relaxation, it is going to, what happens here in a colon, ureter and a bile duct? Parasympathomimetic drugs or parasympathetic nervous system, they cause the spasm. Okay? They cause the spasm, colicky. What is the spasm? Spasm means like there will be contraction. In between the contraction, relaxation will be there. So person will be having a pain like if it is a contraction, because they are the hollow organ, colon, ureter and bile duct. So once they contract, they are going to cause the pain, and then there will be relaxation, contraction, relaxation. So patient will be, whenever there is a contraction, patient will feel pain, and when the relaxation, there will be no pain. So this type of pain we say colicky pain. So parasympathomimetic drug, they cause the colicky pain, they cause the contraction. Now this group of drug, they are going to cause the relaxation. So we can use it for the colicky pain. Chahe wo intestinal colic, we can use this one for the intestinal colic. We can use it for the ureteric colic, and we can use it for the biliary colic. So what are the drug here? We can use the important drug is hyoscine, oxybutynin, here also we can use. Then we have a propanthyline and dicyclomine. So what are the this action, this colicky pain, what is action? It is used here, but what is the action? This group of drug, they exert, remember this word, antispasmodic action. So because of this dicyclomine, it is also used for dysmenorrhea, right? So this is the another site. Now where else this M1 receptor they are present? Now the third site, it is also present in the glands. Now what it does in the glands? So in the glands, if you remember the parasympathomimetic drug, what they do? They are going to increase the secretion of almost all the gland. There will be sweating, there will be lacrimation, tracheobronchial secretion, all the secretion they are enhanced except milk and bile. This is very, very important biopsy question. Okay? And it is also a very important multiple choice question for the PG entrance. So this, now anticholinergic drug, what they are going to do? Their action will be they are going to dry all the secretion. They are going to dry, or you can say they are going to decrease all the secretion. Now what secretion it can decrease? It can decrease the sweating. It can decrease the lacrimation. It can decrease, more important, tracheobronchial secretion. Okay. Now it decreases the sweating. Now sweating, it is very important to regulate the body temperature. Now in the adult we have many other mechanisms by which the body can regulate the temperature, but in the children this sweating, it is very important to help in the regulation of the body temperature. So if you are going to give this group of the drug to the children, now what will happen? There will be no sweating. No sweating in the children. That leads to increase in the body temperature, and that is called atropinic fever. So this is the side effect with this drug, and it is especially in the children. So this atropine, it is not used in the children. If perchance if the child has consumed this datura or anything, then, or fever is because, or we have given the atropine or atropine like drug and the child is having a fever, then immediately stop this drug. Otherwise it can cause hyperthermia. So hyperthermia, it is an important manifestation with the, you will see in the atropine poisoning. So atropinic fever, this is also another important multiple choice question. So atropinic fever, that is because of the, it is not something related with the thermostat, it is because of the loss of sweating. There is no sweating, that leads to the atropinic fever. So another is because it decreases the tracheobronchial secretion also. So where we can use this drug, we can use this one. Because of this, the use is pre-anesthetic medication. See, because it decreases the sweating, so we have an adverse effect. Now it decreases the tracheobronchial secretion, we have a therapeutic uses. We can use this group of drug for the pre-anesthetic medication. Now what it is going to do when we are using it as a pre-anesthetic medication? So most of the pre-anesthetic medication, what they do, they are going to increase the tracheobronchial secretion. लाइक जितने भी हैं आपके स्पेशली इनहेलेशनल वाले हैलोथेन, एनफ्लोरेन, सीओफ्लोरेन, so they are going to increase the secretion, number one this, and number two, so in the bronchi we have a cilia. Okay, you know, in the bronchi we have a cilia and that helps in the clearance of that mucus. So आपका ये है, so in the bronchus we see here we have a cilia, and that cilia, it helps in the removal of this. Okay, this helps in the removal of this mucus. Now what happens if you are going to use the anesthesia during the surgery? Okay, if we are using the anesthesia, then what will happen? Number one, it is going to increase the secretion. Number two, it is going to inhibit the action of this mucocilia. It inhibits this mucociliary clearance. इसको inhibit करेगा. Now it increases the secretion, it inhibits the mucociliary clearance, then what will happen? The mucus plug will be formed. यहाँ पे क्या बनेगा? Mucus plugs will be formed. Okay. So if we use anticholinergic drug like atropine like drug before giving the anesthetic agent, then what will happen? There will be no secretion. अगर secretion ही नहीं है, then even if the mucociliary, if they are not working, it hardly matter. आपके अगर यहाँ पे secretion ही नहीं है, because this drug, it decreases the secretion, it is going to inhibit, there will be no secretion. So then what will happen? No mucus plug formation will be there. Now which drug we are going to use here for the pre-anesthetic medication? Atropinic fever, I already have, it decreases sweating with the atropine. Now For this pre-anesthetic medication which is going to decrease the tracheobronchial, we have two drugs, atropine, and another one is we have glycopyrrolate. Okay, so we prefer glycopyrrolate over the atropine because this is a quaternary. Always remember TL, the tertiary compound, they are lipid soluble. So if I say any drug, if it is a lipid soluble, it can cross the blood-brain barrier. Okay. Now this is a quaternary, it cannot cross the blood-brain barrier. So no central effect they are seen. That is the only reason we prefer. Otherwise both they are the non-selective anticholinergic drug. So this is its action on the glands. Now next is its action on the eye, another organ. Again the receptor is M3. Okay. Now in the eye, the parasympathomimetic drug, what they causes? They causes the meiosis. Okay. वो क्या कर रहे थे? They were causing the meiosis. Now this group of drug, what they are going to do? Use another color. So their action will be, they are going to cause the midriasis. Now where we need a midriasis? ठीक है, आपको कहाँ चाहिए midriasis? ठीक है, midriasis, we need a midriasis when we want to look for the posterior chamber of the eye. ठीक है, आपने जहाँ पे if you want to do the fundoscopy, so midriasis, because of the midriasis, where we can use for the fundoscopy, if we want to see the posterior segment of the eye. So this is eye. This is suspensory ligament. Okay. And with this here we have a ciliary body, and here we have a ciliary muscles, and this is a iris, right? And this is the front cornea. Make a little bit clean. And this is the back of the eyeball. So imagine this is a retinal part. Okay, you want to do the fundoscopy. This is the iris and this is the pupil. If we give midriatic drug, then what will happen? Instead of this much pupil, we will have this much. Because midriasis, then what will happen? We can visualize posterior part. So for the fundoscopy, we have to give the midriatic drug. But if you are giving a midriatic drug, what is the contraindication of giving a midriatic drug? If the person is having angle closer glaucoma, right? Then another, where else we need, what else this group of drug they are going to cause? It causes this one. Then I told you here is a, this is a ciliary body. I'll use another color. Okay. Then go for green color. This is a ciliary body and here are the ciliary muscles. Okay. And same here, the ciliary body and here are the ciliary muscles. Now what is the action on this group of drug? It is going to act on this ciliary muscle also. Okay. Now what is the action of this ciliary muscle? Suppose if you are looking for any object, okay, आप किसी object को, if you look for any object, like we see, suppose this is a pencil. I'm looking at the pencil, I can see. But if I remove it and if I see any other distant object, again the image will be formed where? In the retina. यहाँ पे ही बनेगा image, right? So whether the object is here or whether the object is here. Now how this is possible? If you are focusing the near object and if you are focusing the far away object, it is because of this ciliary muscle. What happens? This ciliary muscle, it contracts. Once this contract, then what will happen? This to this suspensory ligament. Because of this contraction of the ciliary muscle, the focal length of this lens, it changes. And once this changes, then what will happen? The image will be formed on the retina. So ciliary, and what is this process is called? This process is called accommodation. So what is accommodation? Accommodation is because of the spasm of the ciliary muscle or cycloplegic action. Sorry, it's not a cycloplegic. I'll come to that later on. So there's a spasm of the ciliary muscle that leads to the accommodation, right? Now this group of the drug, what they are going to cause? They are going to cancel this spasm of the ciliary muscles. Okay, ये क्या करते हैं? They are going to inhibit this action. And what is this action? So ultimately what they are going to cause by inhibiting the spasm of the ciliary muscle, this action is called cycloplegic action. ठीक है, इसको क्या बोलते हैं? Cycloplegic action. Cyclo is a ciliary muscle, plegic means paralysis. Now this action, where we need it? हमें कब चाहिए? When we go for the refraction testing. जब हम चश्मे के लिए जाते हैं for the specs. So what we do, and we try to read all the letter by contracting the ciliary muscle. So chances are you won't be getting the correct number. So what we do, we put this group of drug to get this cycloplegia. Okay, so this where we use for the refraction testing. So this mydriasis and now because of this cycloplegic action, now what will happen? The image will not formed the right place. There will be blurred vision. This is the side effect of this drug. Okay, so what are the drug? What are the another use of this cycloplegic action? Where else we can use this cycloplegic action? Suppose if the person is having any inflammation, यहाँ पे है inflammation iris में या आपकी cilia में है, so we have a iridocyclitis. This is a inflammation of the iris and inflammation of the ciliary muscle. If this happens, then what happens? There is a spasm of the ciliary muscle. In iridocyclitis, there is a spasm of the ciliary muscle that causes the pain. And what you can give? We can give the anticholinergic drug as a to prevent the spasm of this ciliary muscle. This is the another use of this for the iridocyclitis also, or for the uveitis we can give. So another use of this drug is, I'm writing here because there is no space, uveitis or iridocyclitis. Now what are the drugs we can use here? We have a atropine for the mydriatic and cycloplegic action. We have a hometropine. We have a cyclopentolate and we have a tropicamide. Now which one is to be used? आपको atropine करनी है, hometropine करनी है, cyclopentolate करनी, or we have to give the tropicamide. See, atropine, it is the longest acting. कितनी? It is more than 7 days. Whereas tropicamide, it is the shortest acting. 1 day. So atropine is used in children below 5 years of age. Okay, for the refraction testing, if we want to cycloplegic action. So atropine cycloplegic action, if we want, because the ciliary muscle, the tone of the ciliary muscle, it is very high in the children. Okay, so tone of the ciliary muscle, it is very high in the children. So for that, the atropine, it is the best or most potent cycloplegic action. So we put the atropine in the children. Now what I have told, the atropine, once you are using it in a children, you have to be cautious because it causes the atropinic fever. So what we, an atropinic fever, but here we are using it topically. So topically, instead of using even eye drops, go for ointment. Okay, so ointment, it will be less absorbed from the nasolacrimal duct. So for the children, drug of choice for the cycloplegic action or for the refraction testing, it is a atropine. And whereas for the adult, the drug of choice, it is a tropicamide, because it is the shortest acting, right? So this is for the eye. We have, where we are using it, it causes, what are its action? Its action is mydriasis, its action is cycloplegic, okay, and it causes these two action. And where we can use this one, we can use this one for the fundoscopy, for the refraction testing, cycloplegic action for the refraction testing, and for the uveitis. And what are its adverse effect or a contraindication? Adverse effect, it is causing the blurring of the vision, spasm of accommodation that leads to blurring of the vision, and it is contraindicated in the angle closure glaucoma. And these are the drug which we can use. I'll take this later on. Now, what are the other uses of this atropine and atropine-like drug? So, the most important is organ, which I have left, that is a, not most important, it is a central nervous system. So, in the CNS, almost all the receptor they are there. So, I will not go according to the receptor wise M1, M2, M3. So, we have a drug like one is a atropine. Atropine, it is a CNS stimulant. It causes the agitation, delirium. Whereas another is hyoscine. It is a CNS depressant. Okay. So where we can use this CNS depressant action? One is for the motion sickness. Now, what is the motion sickness? Motion sickness is the person is sick when the person is moving, when the person is traveling. So, you know, if the person is traveling, now which apparatus is responsible for the maintenance of this? That is a vestibular apparatus. ठीक है? Motion में कौन सा आपका vestibular system that works. So, what happens if the person is in motion? This vestibular system, what will happen? It causes stimulation of the vestibular system. It is going to cause a stimulation of the vomiting center, and that leads to vomiting. So this happens when the person is in motion. ठीक है? तो इसमें हमने क्या देनी? We have to give the person this hyoscine. Now when to give the hyoscine? We have to use it prophylactically, not for the treatment. Why prophylactically? Because once the person starts the journey, if this system, it is stimulated and it is going to stimulate this, the person will have vomiting. So we have to give the drug so that this system should not be stimulated. So before the journey, we have to give this drug. So hyoscine, it is available as a tablet and as a transdermal patch. So we give 30 minutes before the journey if we are using a tablet, and if the patch at least 1 day before the journey, or minimum at least 12 hours before the journey. But this patch, it is not available in our country. So this is one use of this atropine, hyoscine. So another use is as a lie detector. So this was used earlier for the lie detector. So what they say, if you are going to give this drug, what will happen? It has got the CNS depressant action. So CNS will be depressed if you are going to give this, and if you are going to increase this, so with the more and more CNS depressant action, what will happen? There is a dissociation between the conscious and unconscious mind, and with the you can say with the interrogation, okay, continuous interrogation with the person, and already with the dissociated conscious and unconscious brain, what will happen? The person will come out with the truth. So he won't be able to make out what is so he will come out with the truth. But nowadays we are not using this one for the lie detection. We do a polygraph test. इसमें क्या करते हैं? Various electrodes, they are attached on the body, and what will happen? So with that electrode, and we monitor few parameters like heart rate ho gaya, blood pressure ho gaya. So what is the idea of or a principle of this is, they say even if the person speaks lie, then what will happen? The visceral function with the, by noticing the heart rate, by noticing the blood pressure, so there are the certain changes which can let you know whether the person is speaking the truth or person is telling a lie. So with the polygraph test, this is the new one. What are the other drug which we can use here? We have a, then after this atropine, number 1, number 2 is hyoscine, number 3 is we have a benhexol, and we have a benchtropine. Now where we are using this one? So this one we are using for the treatment of, where we are using this one, we are using for the treatment of Parkinsonism. इसको हम किस में करते हैं? We are using it for the Parkinsonism. Now you know Parkinsonism, there is a deficiency of dopamine. So this group of drug, it is an anticholinergic, so it is not going to give the dopamine. So which type of Parkinsonism it is used? It is mainly used for the drug-induced Parkinsonism. And the most important drug which causes the extrapyramidal symptoms is chlorpromazine. This is the antipsychotic drug. It acts by blocking the D2 receptor. So once it blocks the D2 receptor, then what happens? The dopamine level, it decreases. That leads to drug-induced Parkinsonism. And how it is going to help in the drug-induced Parkinsonism? They say in the brain there is a balance between the acetylcholine and dopamine. ठीक है? अगर आपका, if this is decreased, then relative increase of acetylcholine will be there. And by giving anticholinergic drug, we are again making this one balance straight. Okay? So there is a balance between the dopamine and, as I'll show you in another slide. If this is, yes. So in the brain, there is a balance between the acetylcholine and dopamine. By giving the chlorpromazine, what will happen? There is a, this balance is disturbed. There is a decreased dopamine and increase, ये थोड़ा weight ज़्यादा हो गया, so I am writing that way. Acetylcholine, this is increased. Now what happens? By giving the anticholinergic drug, what happens? It is going to bring this balance again back to the normal. So this is how this group of drug, it helps. Now where else we are using this atropine like drug, और कहाँ पे हम use करते हैं? This is in the CNS. So I have explained all the drug, this atropine and atropine like drug on the basis of its receptor. Where else we use the atropine? ठीक है। और कहाँ पे अगर एट्रोपिन का आ जाता है, एट्रोपिन इट इज यूज्ड इन अ पॉइजनिंग एज एन एंटीडोट इन ओपीसी पॉइजनिंग, इसमें करते हैं। देन इन द इवन इन द कार्बामेट पॉइजनिंग एंड अर्ली mushroom poisoning. These are the other uses of this atropine. So I summarize this so far. अभी तक मैंने कितना बताया? I have told the anticholinergic drug, they are going to exert its action at all the site, ठीक है, by blocking all the three receptor. By blocking M1 receptor which is present in the stomach, it is going to decrease the SCL, so we use it for the peptic ulcer. By blocking the M2 receptor, it is going to stimulate the heart, so we use it for the treatment of bradycardia, for increasing the AV conduction. By blocking the M3 receptor which are present at various sites, mainly on the smooth muscle like bronchi. In the bronchi it causes a bronchodilation, so we are using it for the bronchial asthma, for the COPD. In the urinary bladder it is going to cause the relaxation of the detrusor muscle, so we can use it for the urinary incontinence or detrusor instability. Then in the GIT, in the ureter and in the bile duct, it is going to inhibit the colicky pain, it exerts the antispasmodic action. Then in the glands, it is going to decrease the secretion, it dries up. By decreasing the sweating, it is going to cause the atropinic fever. By decreasing the tracheobronchial secretion, we use it as a pre-anesthetic medication. Then its action on the eye, it causes a mydriasis, so we use it for the fundoscopy, and it also causes a cycloplegic action, so that action we use it for the refraction testing and for the treatment of the uveitis. Then other uses of this one is in the CNS. In the CNS, hyoscine, we use it mainly for the motion sickness. And atropine, what are the other uses of the atropine? We in the OPC poisoning, then in the carbamate poisoning and early mushroom poisoning. So this is I have summarized the whole chapter. Now what in the MBBS, what question you are going to get from this topic? So usually we ask write the uses of atropine and atropine like drug, ठीक है, therapeutic uses, adverse effect and contraindication of atropine and its analog. I'll write here, the question is write the therapeutic uses, adverse drug action and contraindication of atropine and its analog, ठीक है. So atropine I have told you अलग से therapeutic uses कहाँ पे हम use करते हैं and its analog. So now you can see in the end almost all the drug or a classification of the anticholinergic drug or antimuscarinic drug. So I finished almost all these drugs where they are going to act. So this classification, it is also based on its therapeutic uses. I have taken this also from the KD Tripathi. So we can see here, number one is we have a natural alkaloid which includes atropine and hyoscine. Hyoscine, the another name for hyoscine is the scopolamine. This is obtained from the natural alkaloid. And then semi-synthetic, we have a three: natural, semi-synthetic and a synthetic. Semi-synthetic, atropine, methonitrate, we have a hemometropine, and we have a hyoscine butyl bromide, ipratropium bromide, tiotropium bromide. Then synthetic में आपके क्या आते हैं? Number one is antisecretory and antispasmodic, ठीक है. So antisecretory for the pre-anesthetic medication, and this is for all the colicky pain. You can see here quaternary compound and a tertiary compound. This is an antispasmodic dicyclomine. Valthamate, pyrazapine, this is an antisecretory used for the peptic ulcer. Propanthyline, oxyphenonium, cladinium, ठीक है. Isopropamide, glycopyrrolate, this is also a quaternary compound. See, this is a quaternary compound. That's why I told you this one is used for the pre-anesthetic medication. Then we have a mydriatic. Mydriatic में आपका क्या है? एक तो ये आ गया. This we have a atropine, natural. Atropine is a semi-synthetic. Then we have a cyclopentolate and propicamide. This is also asked sometimes atropine and its analog as a mydriatic. तो आपको atropine उसके analog कौन सी है? Semi-synthetic and synthetic, and its uses as a mydriatic. Then we have a vesicoselective, which acts on the urinary bladder, which we are using for the detrusor instability or the urinary incontinence. We have a, I told you this one, solifenacine, oxybutynin, flavoxate, tolterodine, darifenacine, and solifenacine. Then anti-Parkinsonian drug. We have a trihexyphenidyl or benhexol, procyclidine, and biparatine. And few other drugs which is from some other group, but they exert the antimuscarinic activity, like antihistaminics, tricyclic antidepressant, then antipsychotic phenothiazine, and antiarrhythmic quinidine and diisopyramide. Now, few words about the atropine poisoning or dhatura poisoning. Okay, so manifestation or sign or symptom. This is a accidental poisoning, it can be suicidal purpose also. So what are the sign and symptom of this? D for, we have a dry mouth, dry skin, dilated pupil, and delirium. Okay, this is a hyperthermia. A for agitation, T for tachycardia. This is urinary retention. A for spasm of accommodation, and this leads to blurring of vision. Okay. So these are sign and symptoms of atropine poisoning. Now what we can give, because it is an anticholinergic drug, we have to give the parasympathomimetic drug. So which parasympathomimetic drug we are going to give? It is a drug of choice is, it is a physostigmine, because it is a lipid soluble, it crosses the blood-brain barrier, it is going to reverse both the central as well as a peripheral effects. So that's all about the anticholinergic drug. So if you like my video, please give a thumbs up, and if you have any query, so you can ask that in the comment section.